Okay. And then I would like to introduce our speaker by reading her bio. So I'll go ahead and do that. Okay, so Dr. Solti specializes in medical oncology and hematology with advanced subspecialty training in breast cancer, cancer genetics, and clinical trials research. She maintains additional board certification in internal medicine and is director of the Compass Survivorship Program. Dr. Solti played an important role in this innovative program designed to help patients regain health, happiness, and confidence after treatment. Her commitment to survivorship speaks to her overall practice philosophy of being there for each patient before, during, and after treatment. She wants patients to know, in most instances, that their cancer is curable. In the case of chronic disease, many options are available for symptom relief. And in her spare time, Dr. Solti enjoys yoga, running, hiking, gardening, and spending time with her family. So with that, I would like to turn it over to Dr. Solti to begin our presentation. And again, thank you all so much for joining us.
Thank you very much for the kind introduction. I think there's a small group of us. I have about 40 slides total. I'll try to introduce a little bit for you the idea of cancer genetics and family. Let me just make sure the slides are moving. Oh, slides are not. Oh, here we go. So here's the outline of my talk. As I was preparing for this talk, I thought about, well, why certain people, why certain species do get cancers and other less? What's behind that? So we're gonna dive into a little bit role of gene and genetics. Why is it important to know your family history and how we can use that genetic knowledge, that power to be more proactive. Let's get started. So I found it as an interesting fact, and I was reading some books that elephants rarely ever get cancer. Whereas humans, if you add the skin cancers on the top of other cancers, it's during our lifetime, it's almost 20%. So 1 out of 5 chance that we do get cancer. And animals, including elephants, are just maybe 5%, 1 out of 20. So why is that? In the 1970s, George Peto put out this theory that the larger the animal's body, the longer the lifespan, and the building blocks of the body, the cells have more dividing power. And during those divisions, little mistakes, little mutations could occur. And the more of those mutations accumulate, eventually can cause cancer development. So that was what we called Peto's paradox, and he stated and published that somewhere in the 1970s. But turns out that maybe it's true in dogs, where the larger-bodied animals get more cancer, but it was not true in the whole animal kingdoms, and definitely not true in humans. So as animals, made up of at least 100 times more cells than humans, and 100,000 times more than little mice, but yet their risk of cancer is not more than those small striped mice that run out. So 2 scientists from the UK in the late 70s and during the 80s set out to find out what's behind that. What is protecting the elephants from getting cancer? And as they set to learn more, they come across during their research this tiny protein called p53. And that was what they called first the natural tumor suppressor genes, because what they found, the function of this protein was to stop damaged cells from dividing and growing and escalating, and down the line potentially creating cancer. And if this protein was not able to successfully to stop those damaged cells from growing, then they switch those cells into this suicidal pathway, or what we call an apoptosis type of pathway. So it turns out that humans have 1 copy, 2 versions of the gene that makes this p53 gene. 1 inherited from mother, 1 inherited from father, so total of 2. But what they found that elephants have a total of 20. So multiple more protection in that particular species that help protecting from cancer development. So that was the first successful proof that there are genes, not just they knew about by that time in animal studies that there are certain cancer-causing genes like, virus sarcoma genes. But this was the first proof of concept that there are genes that have a function of protecting our body from cancers. A little bit of primer on genetics. As you probably know, all of our body made out of millions of cells, and in the center of the cells, there's the nucleus, and the nucleus is made out of chromosomes. And in the middle of this table, there are this nice pictogram of how the chromosomes actually look like during our chromosome studies. And we have 23 pairs, both men and women. And the only difference is women have 2X as the 46 pair, and men has X and Y as the 46 pair. And the chromosomes made of a DNA, and that has this beautiful helical structure illustrated on the right. And the DNA has segments. Think about a DNA as an instruction manual in a book, where basically these little segments, these little chapters determine of what is about this book, what we're going to read about. So these small segments called genes made of nucleotide, A, C, T, and G, and these nucleotide, the sequence of nucleotide, these genes, ultimately determine our protein functions. So most of the protein in our body are the effectors. Those are the ones that make our muscle work and make our immune system to fight bacteria. And just basically, those are the workers in our body. Next slide. So when we talk about the cancer genes, it's important to realize that the genetics is just a small section of all the potential causes what can induce cancer in our body. There's a lot more common to have environmental causes, and we know about the radiation effect, the smoking effect, certain cancer-causing viruses and chemicals, and then just normal aging by a faulty division of cells can also contribute to cancer development. So today we focus about heredity and genetic causes of cancers, and particularly breast cancer. There are 3 types of genes that regulate cancer development. The first group called oncogenes, those are the ones that control the growth of abnormal cells. So those are on or off switches. And I like to think about the analogy that like a car, that in order to function properly, you need to have the gas pedal that speeds up when we need to. And we need to have the brake pedal. And of course, we need to take the car to the service to fix the parts. So the oncogenes are the ones that are the gas pedal that speed up the function of those genes. Whereas the tumor suppressor genes, those are the brake pedals. So those control from unruly divisions of the cells, and that way protect against cancer development. And then the third group of genes that involved in cancer are DNA repair genes. And those are if mistakes happen during the cell divisions and gene functioning, then they fix those mistakes during the copying. So most of our talk today will be about tumor suppressor genes that are the protective ones. This is another way of illustrating when we look at a total amount of genetics that only about 10 to 15% in any cancers, specifically also breast cancers, that we find heredity, inheritable genes. Maybe another 10% or so, there's a familial inheritance without any clear genetic background. But majority of our cancers are what we call sporadic, that we do not find any gene in a background. A differentiation between germline or inheritable versus somatic that are acquired mutation. So during our parents, when we have the egg and a sperm, if any of those cells develop a mutation that is carried over to the embryo, And all of our cells will carry on into the adulthood in all those faulty genes. So germline mutations are detectable in every cells of our body, and including our ovum or in man the sperm. So those are potentially can be pushed down and show up on the next generation in the offsprings. Whereas somatic mutation, think about like a lung cancer in smokers. Those changes occur only in the lung tissue during our adult life and stays only in the lung tissue unless it, spread to other places, but not inheritable, not showing up in the sperm or the eggs. And those mutations, somatic mutations, are not inheritable. So today we talk more about the inheritable, the germline mutations. I will spend a lot of talk about the BRCA genes, but very important to know that in breast cancer, BRCA genes are just the top of the iceberg. There are at least 15 other different genes that we know now are part of our genetics that can be part of breast cancer development. But the BRCA has the highest risk, the most commonly and most well studied. And as you recall, these are tumor suppressor genes, so protective genes. And what it means that if they are mutated, become faulty, then they are not able to normally protect those cells or to have protection during growth and division from DNA of the cells. One other basic genetic thought about inheritance mode. There's autosomal dominant versus autosomal recessive. The dominant means that, look at this pictogram, a man versus a woman, and the red X shows their gene, that BRCA gene is mutated. But remember, we have two sets of chromosomes, one from mother, one from father. So in order to develop disease enough to carry just one, even the other one has the normal. And that man marries a woman who has normal BRCA genes, totally functional. And when they have the offspring, this is basic genetics, then half of the children inherit that faulty mutated BRCA genes and they are carrier and may develop disease. But the other half will be totally normal as they inherit the healthy set of the BRCA gene, both from father and mother. Autosomal dominant means that even just one of these mutations, doesn't need to be both, just one of these mutations able to cause the disease. Whereas in autosomal recessive, those are very rare type of cancers, we talk a little bit later, those both need to be mutated. So if we start talking about these BRCA mutations, what are the cancers that are caused by these cancer mutations? The most common is breast cancer, but we also see ovarian cancer in women. Male breast cancer could be associated, pancreas cancer, in men prostate cancer, and a little bit increased risk of melanoma as well, skin cancer. When do we start suspecting that there could be a BRCA or any genetic mutations in a family? So we look at the person's history and we look at the family history. So a red flag if anybody is diagnosed at a very young premenopausal age, before the age of 50. If someone develops bilateral breast cancer, that's rare. Then we always need to think about, could there be some genetic background? If on a same person or a same side of the family, we see cases both breast and ovarian cancers, tubal or peritoneal cancer, those are very similar histologically to the ovarian cancers because the tube, the lining of the tube, and the peritoneum, which is the outer lining of the bowels, are covered by similar type of cancer than ovarian. And they can have cancers, those are very rare, but they also increase the risk that we find genetic background. Male breast cancer, highly related to BRCA2 genes. multiple cases on the same side of the family, 2 or more primary cancers related to the BRCA gene. And we spend more time, especially with this audience, why Ashkenazi Jewish inheritance is important. So what is the lifetime risk for these BRCA genes? There are 2 genes, the BRCA1 and BRCA2, and they are located in chromosome 17 of BRCA1 and chromosome 13 of BRCA2. The BRCA1 thought to be a really, really high risk, up to about 80%. More recent studies found that maybe not as high, but still a lifelong chance that develop breast cancer is up to 65 or 70%. Lesser with the BRCA2, but up to about 55%. And contralateral breast cancers also occurred up to about 40% in BRCA1 and up to about 25% in BRCA2. We see the difference between the male breast cancers. Less chance with the BRCA1 gene, but up to 9% with the BRCA2 gene. Pancreas cancer, relatively rare, but more connected to BRCA2 genes. Ovarian cancer, very highly linked to BRCA1, up to 65% lifetime risk, whereas BRCA2 is somewhat less, about 20 to 25%. And prostate cancer is also more prevalent with BRCA2. This is a busy slide, but I just wanted to point out 2 things. When we talk about biologic subtypes of breast cancer, there are these hormone positive, we call them luminal type of breast cancer. And those, if we look at under the microscope, those are typically the cells that originate from these lumen part of the milk duct. And those luminal type of breast cancer are more common with the BRCA2 genes, meaning hormone positive, HER2 negative type of breast cancer. Whereas if we look at the BRCA1 genes, those are more commonly the so-called basal-like, and the basal cells normally line the outer line of these milk duct, and those are the faster growing hormone negative, or what we call triple negative type of breast cancer. So that's also biological differences between the 2 genes. More triple negative with the BRCA1 gene, more hormone positive with the BRCA2 genes. Let's spend a little bit time about Ashkenazi founder mutations. So think about the story of the BRCA gene as a very large book. And in that book, there are spelling errors occurring. And there are 3 pages of this very large book when these misspelled words are more common. And 2 of those affect the BRCA1 genes, and they are listed here, and 1 affect the BRCA2 genes. And these 3 mutations are very common in Ashkenazi Jewish people. Most of these germline mutations account for familiar breast and ovarian cancers in population in general. The population frequency varies. In a general population could be as rare as 0.1%, but as common as 2.5%, meaning 1 out of 40 people who have Ashkenazi inheritance. And higher penetrance, meaning more lifelong risk occurs with the BRCA1, as we looked at on the previous slides. So why the Ashkenazi Jewish people are special? Why they have this much higher chance compared to a general population to carry one of these 3 mutations? So the history, and I did a little bit of research that, is it all the Jews or just a subset of Jews? So it turned out that Ashkenazi Jews, who are the Eastern European ancestry Jews, from Poland, Lithuania, part of Russia, part of Germany, they are the ones who affected most, as opposed to the Sephardi Jews who are from Iberia, or the Mizrahi Jews who are from Middle Eastern descent. The Ashkenazi Jews are the majority of the worldwide Jewish population, and out of these 10 million Ashkenazi Jewish people, probably 5 or 6 million live here in the United States. So we need to be very aware and very sensitive to their needs and their genetic history and testing. So why we call these founder mutation? If we look at an original population, like in any group of people, could have these mutation occur that down the line may cause cancer. But if the population is diminished and they are isolated either because of migration geographically or isolated because of cultural factors, then within this much smaller population, in the offsprings, that non-mutation is enriched. So generation later, we see a much higher frequency of that original relatively rare mutations. So that's what we call a founder effect. It is not specific for the Ashkenazi Jews. We have seen it in Icelandic population. We have seen it in certain Danish ancestry group in Africa and many other smaller Eskimo population. But this just illustrates why we see the enrichment. So again, everyone who carries a particular mutation is just one out of the two genes. And when we pass down our genetic material to our children, we only pass half of our genome because they get the other half from their fathers. So the chance that we pass down that genetic mutation is only 1 out of 2. So that's important to realize that even if someone is affected, the chance that the children, both boys and girls, only 1 out of 2 or 50%. And it just emphasizes again that 1 out of 40 in the Ashkenazi Jewish population. Now, family history increases further. So we just talked about that maybe this 1 out of 40 of 2.5%, just a random testing if we test everybody from that group. But if we find an Ashkenazi Jew woman who had a personal history of breast cancer, this personal history already increases the chance that we will find one of these mutations up to 21%, meaning 1 out of 5 chance. And if there's a family history in that family of 2 or more cases of breast cancer, then it's already 1 out of 3 chance that on genetic testing, we will find one of these genes. And if not only breast cancers, but breast and ovarian cancers found on one or both sides of the family, then there's a 73% chance that mutations are present. So family history is important. And when we do genetics, that's the number one place where we start of who is affected. Have there been any generations in a family, either side, who have been affected? So when we do family testing, the first step is to put a basic pedigree together. And it's just illustrate what are the little charts that on a pedigree, where squares are men, circles are women. If they are connected, like here in the center, they are a married couple, and these are their children. If someone passed away, we usually cross a line. And then carriers are usually showed up either shadowed, whether carrier of one genes or more than one genes. So let's look at a typical BRCA pedigree. The little arrow on the bottom is a person who is being counseled today. So this girl is now going through genetic counseling. And as you see, her mother, marked here in dark, had breast cancer at a young age of 42. And mother had 2 sisters and a brother, and one of her sisters had ovarian cancer. And the brother is not affected with any cancer, but the brother had a daughter, this girl's cousin, who also had a young age breast cancer at 38. And mom's mother, the siblings' grandmother, had ovarian cancer, and she passed away at the age of 49 from ovarian cancer. So what is very notable in this pedigree that 3 generations are affected, and they are all very young age. So younger than 50 except the ovarian, but breast and ovarian all in young age. That is already a red flag that we should look for genetic testing in this family. So what is happening during genetic counseling? Genetic counseling is not just, putting the pedigree together and sending out the test. It involves a lot of helping that person, helping that family of dealing with what does it mean if you carry the gene? What are the potential outcomes? Can it affect the family and have further testing in a family? How about the psychosocial aspect? If that person want to have children, what would be the timing and best time in their life to think about children and think about preventative measures? And how can we support the whole family? Which genetic labs we use is also important. 20 years ago, there was only Myriad who were able to test. And then in the last 2 decades, multiple other genetic labs started doing what we call multi-gene panel. And that's important because 20 years ago, if you wanted to do genetic testing, it was only available the BRCA1 or BRCA2. And then you had to wait if they're negative, and if there's still a suspicious family history, then maybe allowed one more test, the TP53 that we talked in the very beginning. And that was it. And now the smallest panel we do nowadays is basically at least 48 genes. And many panels are 84 and plus genes. And those cover not just breast cancer, ovarian cancer, but multiple other genes, including brain tumors, kidney cancers, prostate cancers, and such. Many years ago, as you recall, there was 23andMe, who had very, very much advertised directly to the consumer that we test all diseases, we test your genetics. But they only tested the BRCA Ashkenazi Jewish mutation. So it was a little bit misleading that people felt that, oh, I'm off the hook, all these 3 genes are negative, and yet there are multiple other genes that would be involved. So important to use a very respected lab who have a large genomic panel, and that's what we use nowadays. What are the potential outcomes of genetic testing? So the test either come back as positive, meaning pathogenic or likely pathogenic mutation present. And that is followed by a lot of counseling. What does it mean? How does it affect me? And how does it affect my family? Or the test come back negative, which means benign or likely benign variant, and we don't need to worry about inheritable genes. So in that person or that family, then the chance of cancer is just the same than the average population. Or rarely we can have a result of variant of uncertain significance, which means there is some structural changes occurred on that particular protein, but is not a cancer-causing variant. And most genetic labs collect those information, and years later we get results back that now we identify these particular variants and it's not tracking with cancer. So majority, I would say 95% of those VUSs are non-cancer causing mutations. This is a sample of how the genetic report looks like. So on this genetic report, it lists that breast next panel was done, which lists all of the genes down here. This was a 17 gene panel that searches for all the breast cancer associated genes. And they found a pathogenic mutation in the BRCA2. And on the report, they list of what does this mean? It's a stop codon or a deletion. How does it affect the function? And what are the associated cancers? So what happens if someone is tested positive for one of these mutations? The first and most important thing is be proactive, start screening. Normal screening for breast cancer in average risk women typically starts, well, guidelines change, but anywhere between 40 and 50, and start mammograms. However, because BRCA mutations or related cancers start at very young age, potentially in their 20s, the guidelines state that if someone carries the BRCA1 or 2 mutation, start not only breast exams, but also start breast MRIs by the age of 25. because the breast tissue in those very young women is usually very dense, the mammogram is delayed until age 30. And at that point, we like alternate. So once a year mammogram, once a year MRI, and a tooth test are basically alternate every 6 months. How about screening for ovarian cancers? Well, unfortunately, it's not as straightforward. And the reason is there's not a great screening method. We can use transvaginal ultrasound, but in order to find a decent size of lesions on the surface of ovaries, it may not show up on a regular ultrasound. And there's this CA125 blood marker, which is a tumor marker screened from the blood from ovarian cancers, but not every ovarian cancers make that tumor marker. So if nothing else, they said, well, you can consider starting at the age of 30, but really preventative surgeries are much more important to prevent ovarian cancers, as they are more of a silent killers where the screening is not as great than for breast cancer. The current recommendation, if we think about preventative surgeries, meaning removing the tubes and the ovaries, as the BRCA1 gene starts at younger age, generally we recommend consideration of those preventative surgeries between ages 35 and 40 for BRCA1 carriers, and by the age of 40 or 45. And of course, keep in mind that, those young couples may want children, so after completion of childbearing. The Angelina Jolie revelation really spurred up these preventative surgeries. She was the one who was very upfront and open and published her story that she went through bilateral preventative mastectomies as well as bilateral sapping oophorectomies. And she stated that I don't want my children to live in fear that they don't see their mother grow up like she had with her mother. So she took these proactive steps. And after her article, the preventative surgeries increased by almost 30%. So here is the success story. Now, for prostate cancer screening and pancreas cancer screening, generally we recommend start PSA testing by the age of 40. Digital rectal exam is still done, but not super sensitive. Now is more emphasis on prostate MRIs. Pancreas cancer screening is recommended if there is already a pancreas cancer in the family. So if the family is only breast and ovarian, not recommended. But if there had been cases of pancreas cancer, then we do yearly screening, start at age 50, either by an MRI, MRCP, or an endoscopic ultrasound and MRI alternating every other year. Again, timing of these risk-reducing procedures, since the breast cancer hit very young age for BRCA1 and a little bit later BRCA2 carriers, we talk about bilateral prophylactic mastectomies already starting at the age of 25 or 30 to discuss. The ovary removals, 35 to 40 for BRCA1 gene carriers and 40 to 45 for BRCA2 gene carriers. So the message is way before menopause, because these women develop cancers in a very young premenopausal age. A word of chemoprevention, which the message is controversial. Tamoxifen has been developed for preventing, not just treating breast cancer in premenopausal patients, but also use it for preventing, but data only available for 35 or over. And tamoxifen and all the others, raloxifene, exemestane, which are only used in postmenopausal patients, they only prevent the hormone-positive breast cancer, which we are well aware that the BRCA1 gene are usually triple-negative hormone-independent cancer. And none of these medications shown to be a life-prolonging measure in a setting of BRCA genes. So usually less of these medications, more discussion about preventative surgeries. One word about targeted therapies. If someone have the BRCA1 or 2 mutation, and happen to have advanced breast cancer or ovarian cancer, now we have targeted medications, these called PARP inhibitors, that shows a very good effect and especially in a metastatic setting, control from disease progression for years in a BRCA1 and 2 gene carriers, and potentially allowing these patients not need to have chemotherapies. Lastly, a word about Fanconi anemia. Fanconi anemia is an inheritable blood disorder, basically a bone marrow failure syndrome. And a Fanconi anemia is caused by a complex of gene, it's listed here in the center, Fanconi anemia complex gene, that their normal function is to repair DNA double-strand break. So during the cell division, some breaks, some misreading occur, this gene complex set up to repair those and keep the normal function of the brain. So there's a lot of Fanconi type of gene, but part of the complex, as you see here, the BRCA1 and BRCA2 also could be part and function as part of this complex. So any of the complex, if those are misfunctioning and mutated, those lead to lower blood production, especially low white blood cell count, low red cell count, and eventually leukemia formation, skin pigment changes, body size changes, kidney dysfunction, missing kidneys, brain and spinal cord abnormalities. This, as opposed to the typical cancer type of BRCA1 and 2 mutations, these are autosomal recessive inheritance. And what it means that even though in this pictogram, both a father and a mother carry these mutations, one of the Fanconi anemia or one of the BRCA mutations, but in order to manifest this Fanconi anemia complex, they have to have both of the mutations in the same person. So mom and dad both carriers, but they don't have the clinical syndrome. And one of their children is totally normal without inheriting any of the gene. Two also have been carriers without manifestation of the disease. But the fourth one, who got the affected gene both from mom and dad, has the abnormalities. So when we talk about inheritable BRCA mutation, it's important to screen not just that person, that woman in front of you, but perhaps for family counseling, also the husband, to make sure we don't find these autosomal recessive mutations that can create Fanconi anemia in the future. So back, why this genetic counseling is important? Because knowledge is power. You will be able to learn about what steps you can do to prevent cancer development in multiple organs. You could be protecting your children by giving them a tool to have that test for the known familiar type of mutation. And then there is a lot of experts, genetic experts, oncologists, OBGYNs, and family counseling experts ready to help those families who are affected. So in my mind, carrying any of these mutations is not a death sentence. It's very manageable. It's very preventable as long as we think about it and proactively do about it. And with that, I will stop and open it up for questions.
Thank you so much, Dr. Solti, for a wonderful presentation. I'm going to stop the recording right now.